Colorectal surgeon, Department of Surgery, University of Malaya Medical Centre's very own Dr. Mohamed, Rezal, Abdul, Aziz. Our topic today is colorectal cancer. This has seen a surge, and we will be talking about the ups and downs of it right here today. Welcome to the studio, Doctor. How are you today?
Thank you very much, KG.
Yes, thank you.
Good morning, everyone. Assalamualaikum. I'm good today. I just back from the clinic and I'm now here giving a talk.
Yeah, it is a very busy day for you. So thank you for taking the time. And you know what? Let's get straight with the questions. Now, what is it that you do in your department? Do pray tell us.
Right. As my position at the moment, I'm a consultant colorectal surgeon in University Malaya that work in University Malaya Medical Center or PPUM. So my job actually entails mostly colorectal disease. This can be a benign or malignant disease. Mm-hmm. So the malignant would include colorectal cancer. Mm-hmm. So my niche is actually on the peritoneal disease, which is a stage 4 colorectal cancer. Curative stage 4 colorectal cancer.
Mm-hmm. So peritoneum, that is that one layer within your stomach itself, right?
Very good. Okay. Yes, correct. This is a lining of the abdominal wall, we call it, but this is the inner abdominal wall. Mm-hmm. And also it lines on the stomach and also the small bowels and the rest of the organ in the abdomen.
Mm-hmm. All right. So doctor, now can you tell us more about colorectal cancer and what are some of the latest statistics on colorectal cancer in Malaysia?
Yes, statistics shows that colorectal cancer is still the highest, and also the commonest cancer in Malaysia, and for men, mm-hmm. and then but for women, breast cancer is topmost for women, and the second commonest is the colorectal cancer mm-hmm. for women, but for men is colorectal cancer is the most commonest. The most common.
So it means like if they do get a cancer, the highest chances would be colorectal cancer.
Correct. Yeah.
All right. Now let's talk about the risk. Who is at risk of getting colorectal cancer? What are the contributing factors that can actually cause colorectal cancer?
Yes. The one who at risk is the one who has family history, the one who has inflammatory bowel disease, and other things, precipitating factors, which include the one who have consumed cigarettes. Cigarettes consumable, high cigarette consumable, and also the one who have required more red meat compared to the white meat. Mm-hmm. And yes, and also nowadays, all of us, we can say that it's a very busy lifestyle. It's not like the last time before. And then means like our all of us have to, let's say in a family, probably both parents has to work, mm-hmm. and so all this increased stress. Mm-hmm. Stress also can precipitate all of this.
All right. So it seems there is genetic, there is lifestyle, and there is also just the wants and the needs of the normal life, the normal day that can cause all of this. So genetics and lifestyle do play a factor into both of this. All right, doctor. So what we're going to do, we're going to be taking a very short break. And of course, for those of us who are currently listening via our Facebook Live and the such, you can definitely ask us questions if you would like to do so. And if the questions are pertinent to the current topic, we'll be more than happy to answer them there. And right now, we'll be taking a short break. We will be right back. Don't go anywhere. This is TRAXX. Welcome back. That was, of course, Trapped with Headstrong right here on your favorite station. You're currently with us on Health on TRAXX. We are talking to Dr. Mohamed Rezal Abdul Aziz from the Department of Surgery. He is a consultant colorectal surgeon under UMMC, otherwise also known as PPUM. Today we're talking about colorectal cancer. Now, let's talk about the symptoms of the colorectal cancer, doctor. Could you tell us more about that?
Among common symptoms in colorectal cancer are altered bowel habit. So what is altered bowel habit? So altered bowel habit is when a patient who has constipation or diarrhea, sometimes normal stool. So this can happen over a period of months. So let's say normally patient pass motion once a day or once every 2 days, but now patient pass motion, let's say every 3 days, and it's hard stool or sometimes watery stool, and sometimes it's become normal. So that is that's what it means by altered bowel habit. So other things is, can this patient see any blood in the stool? So blood mean is a fresh blood, is a red blood in the stool, but sometimes the stool also can become black like hair. So with this with this symptom, this is an indication that the tumor is or the growth is actually bleed, and when the stool pass out, it can present with fresh blood which mixed with the stool, or it is a dark stool. Thirdly would be abdominal pain. Not so common. It's normally present as around 30% of the patient. So it's just imagine that the colon is a soft pipe and you have a tumor inside or growth inside the colon, or the growth inside that pipe, and it's growing and growing and is going to get blocked. So that's the reason that the patient will have pain. So sometimes it's big enough, it can grow out of the pipe or the colon, it can hit the organ nearby, so that can also cause pain. So normally the pain would be a crampy type pain, and is a periodical or episodial pain. We normally mention about describe as a colicky pain. Other things would be weight loss and anemia. Anemia means is low blood count. So means the patient suddenly go pale, but sometimes it's not drastic, like you can't actually see that the patient goes pale, but the blood count is low, and sometimes patient present to you or complain to us that patient experience palpitation, lethargy, and generalized malaise. So this will alert us that, okay, this patient may have anemia and we have to investigate further. Other thing would be intestinal obstruction, as I mentioned, that when the tumor grows inside the lumen or inside the colon, it can block. So that's one of the common presentation in colorectal cancer.
All right, so that is some of the symptoms that can be seen by the patients themselves, especially if they have been going to the toilet properly, but then they do present altered bowels, and inconsistency. Then that is when they can come and start seeing a doctor to get a better idea what's going on. And let's talk about if our listeners or anyone is having the symptoms, what should be their steps? What should they do?
All right. Okay. If any of the patients present or experience these symptoms, of course, they should seek a doctor. It can be from a general practitioner or the hospital in the specialist unit. But it depends on what type of the presentation is. But let's say patient present acutely as a torrential bleed, causing palpitation, very weak. That patient actually should refer to hospital right away. If patient present with intestinal obstruction, also need to present the patient to the hospital right away. The one that patient should go to general practitioner is the silent symptom, and out of the sudden that patient have lose weight, they can't wear their normal clothes, the clothes is loose. Then they will start to wonder why, and then altered bowel habit. Sometimes they have pain, abdominal pain, and sometimes not. So this kind of patient should go to the GP, and then after that, relevant tests will be conducted at the center.
Right. So, and as for the diagnosis, right, like for instance, you've already met the doctor, you've already known that you have colorectal cancer. What happens after that diagnosis?
All right. Okay. So first thing we need to confirmation is tissue biopsy. So hence this patient need to have a colonoscopy. But prior to that, let's say patient has a silent symptoms. So patient can have IFOBT, means that we detect is there any blood in the stool. So this is not a fresh blood that we're looking at. This is by the chemical level that we are testing to see if there's any blood in the stool. Is a test kit. So once the patient have that, so hence this it came back positive, this patient require a colonoscopy. So what is colonoscopy then? So colonoscopy is actually looking into the colon. This patient will require a bowel preparation, which we have to cleanse the bowel so that we can see the colon. Then after that, on the day of the procedure, this is not an operation, it's only take around 10 to 15 minutes. We will check patient vital signs, which is blood pressure, the pulse, oxygen saturation. Then we will give sedation. Then after that, we will insert the colonoscopy, which is the scope, looking into the colon. So what are we looking at? We're looking at if there is a growth in the colon. Can we pass through the growth or not? Means that is this growth blocking the scope to pass through, or if the patient has two growths at one time, because that will determine us how we're going to prepare this patient for operation later on. So that's part. Of course, when we found there is a growth there, we need to take a biopsy. Means, what is a biopsy? Biopsy means to take a piece of the tissue so that we can send to the lab and then test it and confirm it whether this is cancerous or not. Only then we can tell that this patient actually has colon cancer, colorectal cancer.
All right. So, and let's talk about the stages of colorectal cancer, doctor. What are the stages of it and the percentage of successful treatment?
Right. Okay. So the how do we stage this patient? Of course, all patients are very anxious when they come to see us in the clinic. The first thing they will ask, what stage am I? So we can only know that is when we do this CT scan, which is the radiology test scan to scan on the thorax, which is the chest, and the abdomen and pelvis. So this will tell us whether the growth has spread, or we often use the term metastasis to the liver, to the lung, or peritoneal, or any other organ nearby. So if it is organ nearby, we don't call it metastasis. That means the tumor has growth and locally advanced at the nearby organ, which is near the cancer itself. If it is spread elsewhere, only then we can tell that this patient has spread, which is stage 4.
Right. So we're going to be taking another short break, doctor. We'll be right back. And we are talking about colorectal cancer with Dr. Mohamed Rezal Abdul Aziz, a consultant colorectal surgeon with the Department of Surgery, UMMC. We will be right back. Don't go anywhere. Welcome back to TRAXX, and right now we are talking about colorectal cancer with Dr. Rezal, who's a consultant colorectal surgeon from UMMC. And doctor, what are the treatment plans available for patients with colorectal cancer?
The treatments actually depend on the stage of the patient. There are stage 1 till stage 4, and stage 1 would be upfront, we call it, which is like surgery. Okay, so stage 1 is surgery. Stage 2 it depends on how the patient present to us. If patient is asymptomatic, and when we work the patient up, we investigate, then this patient is more or less, we can say that this patient is stage 2. So hence that this patient also require upfront surgery as well. Now for stage 3 and also stage 4, which is that is the most commonest presentation of patient in Malaysia, actually around 54%. Normally this patient, we have to ensure that this patient is whether the cancer coming from the colon or the patient coming from the rectum, because the treatment are different. For colon, mostly the treatment would be surgery first, followed by chemotherapy. Whereas for rectal cancer, they will require chemotherapy first. Then we reassess with imaging. Then patient will go for surgery. Then after that would be chemotherapy. So chemotherapy, surgery, chemotherapy. So that is for rectal cancer.
All right.
For stage 3 rectal cancer. Now stage 4. Stage 4 is, we have to treat stage 4 very precisely. First, we want to know whether can we cure this stage 4? Hence, can we remove this cancer altogether? Commonly, they spread into the liver. So, can we remove the cancer in the liver? And how do we remove it? Some it require radiofrequency ablation, which we call it RFA. In a layman term, is actually we burnt it. This cancer in the liver, but it has certain criteria, not all. Means like if they have small lesion or small tumor in the liver, let's say less than 2 centimeter, and then it's not many, it's around 3. So that can be burned. On top of that, we have to remove the cancer in the colon. So in that case, we'll talk about curative stage 4. And other thing, if they present or metastasis spread into the peritoneum, the lining of the abdominal wall, then this patient, we have to reassess differently. Means that he will have to have a keyhole operation to look the distribution of the disease on the abdominal wall. We have to score them. Patient will have a different kind of scans, we call it a PET scan, to know can we detect any other cancer elsewhere. We want to, as long as the cancer is contained in the abdomen, we can still do a curative surgery, which is, we call it cytoreductive surgery, and HIPAC, which is hyperthermic intraperitoneal chemotherapy, which means we give a heated chemotherapy after we remove all the cancer in the abdomen. The heated chemotherapy will be directed into the abdomen for 1 hour during the operation.
So that is very, very targeted.
Yeah, correct.
And that is your specialization.
Correct.
Okay, all right. And so, of course, when you talk about colon cancer and rectal cancer, the way you approach it is very different. That is because for the colon, you can remove parts of the colon and the human body can still function normally. But with the rectum, that doesn't work that way, does it?
Yeah, so So basically the main thing here is for patient to achieve overall survival and also to reduce down the recurrence rate. So for rectal, so the treatment option internationally is after assessing. There is a role of a neoadjuvant chemoradiotherapy. That means they will receive a chemo and radiotherapy prior to operation. Then after that, we will reassess them with the MRI. Then we will do the definitive surgery, right? Mean we remove the rectum. Then after that, after that, then we can actually tell exactly the stage of this patient. So from that, this patient will require further chemotherapy after that. Yeah.
All right. Thank you so much, doctor. And what is your advice? You could suggest a point of reference that maybe our listeners could go check out about colorectal cancer and cancer awareness itself in general.
Yes. My advice is the disease is actually colorectal cancer is preventable disease, and then don't be afraid, so because that all, no matter what stage that you are at, we are here to help you at any stage that you are at. And of course there is a reference that you can go to, which is the Corum, corum.com.my, and also the Rebung, REBUNG. Okay, these are the two commonest websites that often talk about colorectal cancer and also patient experience with colorectal cancer and who underwent operation.
Right, thank you so much, doctor. Now, before we end for the day, is there anything else that you'd like to add for our listeners?
I wish that all people in the society aware about the colorectal cancer, how they present it, and then get it checked early, because it is a preventable disease. As I mentioned earlier, majority of patient or population in Malaysia present at stage 3 and 4, and hopefully we can reduce down to the detection at stage 1 and 2, which is they will have a better prognosis.
Yes, the awareness needs to be there.
Correct.
All right. Thank you so much, doctor. Now, before we go, just one more question. How could you get earlier prognosis? Like, how could they actually find out earlier if they are facing cancer?
Yeah, certainly. So this is what we call about screening. So basically, screening is to detect the disease sooner without patient has any symptoms. Okay, so who do we test it? Normally the patient who is 50 years old, so they need to have a screening test done even though there are no symptoms. So what does it entail? One is the fecal occult blood test. So basically this is a test in the stool to check if there's any trace of blood in the stool. So if patient have that, then the patient required to have colonoscopy. All right. So other things would be a colonoscopy.
And that needs to be done regularly after they reach a certain age.
Yes, basically our targeted screening is at 50 years old.
At 50 years old. All right, so I've got about 15 years to go for that, so it's okay. Well, anyways, doctor, an absolute pleasure talking to you today, and I think a lot of people have, because we always hear about the other kinds of cancers like breast cancer and all of those, but colorectal cancer has not been discussed much on this station for now. But thank you so much for educating us today, and thank you for the work that you're doing as well. And I hope you have a good day.
Thank you.